So I had a patient, and it gets brought up quite a bit, is you're encouraging me, doctor, to lose weight, and then now you're asking me to put weight back on.
Yep.
So can you explain why that's beneficial to do that? We're asking people to lose weight, but then we're asking them to put a jacket on with weight back on it. Why are they not better just staying overweight?
Yeah, so maybe I didn't touch on that before, that a big risk factor for your bone health is also being slim. So people that have always been, had a lower BMI, they're more at risk of osteoporosis, just because they've put less weight and stress on their bones throughout their life. Whereas someone that is quite overweight, generally their bones should be in a bit of a better position. So yes, when they're losing weight, then we want to just still stimulate that same stress that they had on their bones before.
Today I'm joined by Dr. Alison Mooney, an experienced GP with a passion for holistic evidence-based care across every life stage. Alison brings a wealth of knowledge about women's health through midlife, including the often overlooked link between hormones, bone health, and the risk of osteoporosis in menopause. Osteoporosis is significantly more prevalent in postmenopausal women due to a decline in estrogen levels, which is crucial for bone health. Research indicates that up to 20% of bone loss can happen during these stages. In Australia, in the population over 50, 66% of people have either osteoporosis or osteopenia, but often don't know. But although widespread, the good news is that this condition is highly preventable. Join us for a deep dive into what causes osteoporosis, how your hormone shifts play a role, and what you can do right now to protect your bones for the long run. Whether you're currently experiencing symptoms of perimenopause or postmenopausal or planning ahead, this is a conversation every woman needs to hear. Let's get into it. Dr. Alison Mooney, welcome to the podcast.
Thank you for having me.
Friend and colleague, I am so delighted to be able to pick your brain and share your incredible knowledge around everything menopause, but especially bone health. I'd love to start by asking you to share your story and why you've ended up with such a specific interest in this area.
Yeah, so when I was 17, I went away to uni and lived a couple of hours away from home. Didn't look after myself very well at all. I was binge drinking. I was not eating very well. I didn't exercise ever. And my period started for me when I was 11. And then I seem to remember around that time of going away to uni, my period just kind of became irregular and then it stopped completely. And I wasn't studying medicine at that point. I was doing biomedical science, trying to get into medicine desperately. And so I didn't really understand the implications of what that meant. And I let it go for quite a long time. So by the time I went and got it looked into, at 19, I was then diagnosed with something called polycystic ovaries, where you're not ovulating, and you have very low estrogen levels. And because of that, in that time frame of not having a period for sort of 18 months to 2 years, luckily somebody sent me for a bone density scan at that point, and I was diagnosed with something called osteopenia, which is thinning of the bones, something that we don't see in people normally till they're sort of postmenopausal in later life, and I was diagnosed with that at 19. So I've become very passionate about trying to educate other women about how they can think about their bones and also look after their bones as they age.
Okay, amazing. And so what happened then for you? So you have this diagnosis, but you're only 19
Yep.
and you're not a doctor at this
Not a
point, so you
doctor.
don't have much knowledge. What did you do from there?
But to be honest, I was a bit lost. I don't really remember being told much other than making sure I was having some calcium and getting some vitamin D, which in Scotland is a bit of a struggle, as you would know from where you're from. So yeah, I don't really remember. And in that consultation as well, I think I saw a fairly junior doctor. And part of polycystic ovaries, it comes with it having some fertility problems. And they actually told me at that consult that I would never be able to have children. And it was just almost, I got told I had like
OMG.
ancient crumbly bones and that I would never be able to have children in this one consult. when I was away from home, I was on my own at that appointment and I was obviously devastated. So I think for quite a long time, I just didn't really quite know what to do.
And maybe the fertility bit was maybe more of a focus, wasn't
Yeah,
it?
absolutely. Yeah, absolutely. And then I did take up running. And I remember running around this local park at uni through all weather. And I'd never been someone that had really exercised before. I used to play netball at school, but I was quite a chubby little thing growing up in Scotland.
I can't even imagine that.
Well, I was actually quite overweight until I really got to, like, my mid-teens, and always got sort of picked last for the sports team, kinda shied away from sports because I always just thought, "Well, I'm not good at that, that's not my thing," and then really started to just take up running, and I remember I ran a 5K and was absolutely thrilled with myself, and then just kind of took off from there, and obviously at that point, I was still in the phase where I was able to thankfully build bone again fairly readily. So following on down the track, my bone density scans did return to kind of low normal levels, but it's something that I've always been very aware of since then.
Okay, so what is osteopenia and what is osteoporosis?
So, I guess the way that I explain it to patients is that osteoporosis is a spectrum condition. It starts off, say, you have normal bone density on one side, and at the other end of that spectrum, there's osteoporotic bone, and in the middle, there's something called osteopenia. So, normal bone is quite dense. It's, got lots of minerals in there. It's not likely to fracture. And then osteopenic bone is when that bone's just starting to lose some of its density. And then osteoporotic bone, it becomes like it's just lost all of its architecture. I think I thought when I was at school that your skeleton was like that thing hanging in the corner of the classroom, and it was just this really solid sort of static thing that just supported you. But your bone is very much a living tissue, and it's in this constant state of turnover and remodeling. There's bone being put down and bone being taken away. And osteoporotic bone is when really your bone has just been taken away much faster than what you can build bone. It loses that architecture, it becomes very fragile. And the main problem is that then it's at high risk of fracturing.
And so, what is the connection between osteoporosis and peri and postmenopause? Because it seems to be something that we're all talking about. So, would you mind explaining that to the listeners?
All women will reach their peak bone density when they're in sort of their mid 20s. And that's really driven by estrogen. So there's a huge surge of estrogen at puberty. And then that sort of turnover that we talked about is very much more balanced towards building bone rather than taking away bone. So you reach that peak density. After that, it's a sort of very, very slight decline until you hit that 5 years around menopause. And then women can lose between 10 to 20% of their bone density over that 5 year period. And then after that, there's just an ongoing continual decline. So, I think if we see someone in perimenopause or even before that and they're osteopenic, if you don't do anything at that point, the natural follow on from that is that they will become osteoporotic at some point in future.
Okay. And so, whenever we think about how we would find out if someone has osteopenia or osteoporosis, can you tell us how we do that?
So the easiest way to find out is to have something called a bone density scan, or it's otherwise called a DEXA scan. Anybody can have one. You just have to pay for it basically for a lot of women. But you can ask your GP for a referral for a bone density scan. It costs between $100 and $150. And it's a very simple test. It's low radiation. You lie on a bed and an arm just comes over you and measures the bone density at some specific sites. So usually your lower spine and your hips, the top of the long bones in the legs, your femurs, and at your wrist, to give you that score as to whether your bones are normal or they're osteopenic or they're osteoporotic.
And so, I know that we have a statistic that 1 in 4 people in the population have osteoporosis over the age of 50.
Mhm.
But the reality is that probably most of them don't actually know that.
Mhm.
And I know that you and I are both very passionate about our peri and
Yeah.
menopausal patients, where we have them all trooping off to have their bone density scans. Um, why do you think that there is a reluctance, perhaps, for people to have these scans, or do you think that doctors just haven't really been taught to do it,
Yeah.
or it's because of whether it's getting a rebate from the government
Yeah.
to have it done,
Yeah.
or why do you think we're kind of lost our way a little bit with this, haven't we?
Absolutely. Like I think for a lot of women it's just total lack of awareness. Most of us go about our days to days not really thinking about our bones. We think more about what we look like on the outside and not focus on our skeleton. So yes, the government, I suppose, doesn't make it that easy in that the rebate comes for a funded scan when you turn 70, and we can send anyone for a free scan. But at that point, it's not really become a screening test anymore. It's more picking up disease at that point. I don't know about you, but most 70-year-olds, if it's their first scan, I'd be betting that they were already osteopenic or osteoporotic. Um, the government will fund it for other conditions in women that are under age 70. So, for example, if you have a high risk factor for having osteoporosis, then you will be able to have that funded much earlier. But yeah, I think it's just a complete lack of awareness from patients, but also from doctors, really, to encourage people to go and do it and the reasons why we want you to do it.
And if we think about those groups who are at increased risk, so our polycystic ovarian syndrome patients who are not having cycles at
Yeah.
all, who else are high risk people?
Yeah, so similar to the polycystic ovaries who are not having periods, there's another condition basically that's caused by kind of maybe over exercising and not eating enough. And the first thing that your body switches off is your fertility, so you can stop ovulating. So a lot of athletes might be at high risk of osteopenia and osteoporosis. Then there's other sort of autoimmune conditions like celiac disease, rheumatoid arthritis, thyroid disease, diabetes, where you're at higher risk. And then there's a lot of lifestyle factors as well. So if you're a smoker, if you're drinking more than two standard drinks a day, you put yourself at increased risk. A huge one is obviously having a family history of osteoporosis. If your mum's broken her hip, or your granny broke her hip, then you're at higher risk. And age is probably the biggest risk factor, and also the age that you go through your menopause. So especially women under 40 have a very premature menopause, or women who have a menopause between the age of 40 and 45 and have an early menopause, they are at higher risk.
So basically, pretty much everyone should be thinking about having
Yes.
having
Yeah,
one to see where they are.
absolutely.
And I think one of the things that I want to get across as well is that you don't usually know that you've got
Mm.
osteopenia or osteoporosis. There's no pain
Yeah,
involved until you've got a fracture.
yeah,
And by the time you have pain from your bones related to this problem, it's kind of like the horse is already bolted.
yep,
We want to get you way before that
yeah,
stage so that we can do something about it.
yeah.
And so if someone already has on their scan osteoporosis, is it is it too late? Can we reverse them back? Or is it like you can just make it a bit better?
Yeah. Look, I think if someone already has osteoporosis, the main thing that you're trying to do is prevent fractures. So, yes, you may be able to partially improve their bone density. So, say women went on to hormone treatment and particularly estrogen treatment, their bone density can improve within 2 years of treatment by up to 5%. But unless we're educating women about all the other things that they have to do, then that's all we're focusing on is increasing the bone density. But, if that woman's balance is awful and she falls over, she's still at very high risk of fracture. So it's about the whole gamut of what someone can do to really protect their bones.
Yeah, absolutely. And so if we know some of our listeners are a bit younger, what can you do to make sure you lay down really great bone?
Yeah. So as I said before, it's when you are 25 or so, that's when you've reached your peak bone mass. So even People that have young girls, really encouraging them from a young age that they need to be very active, every day trying to be active in some shape or form and making sure that they're getting enough calcium in their diet. So calcium is always best to come from a dietary source. For a postmenopausal woman, you're trying to be getting 1,300 milligrams of calcium a day. And then getting your vitamin D is very important to make sure you're absorbing that calcium from the gut. And vitamin D, obviously, we largely get it from the sun. It's in some food sources like fatty fish and egg yolks, but mainly it comes from the sun. And, if you think you're not meeting your vitamin D requirement, you would be best off to take a supplement of at least 1,000 units per day. Um, don't smoke. Don't vape because you might end up smoking. Obviously, thinking about alcohol as well, as that is really a significant risk factor. So, trying to limit within the guidelines, which is less than 2 standard drinks per day, a couple of alcohol free days a week, and no more than 10 drinks in one session.
And do we know why? Why is alcohol affecting our bones? Do we know?
I don't know, actually. That's a good question. What do you think?
I don't know. Is it just maybe that if you're drinking too much, you're not, potentially making the other great lifestyle choices that
Probably.
perhaps go
Yeah.
alongside it?
I don't feel like going for a run. I've had even more than one the night before.
Yeah, absolutely. Yeah, I don't know. I'm gonna have to look into that
Yeah.
one. So why are women so sort of outnumbered, or sorry, why are women outnumbering men so much in this diagnostic category?
Look, it mainly comes down to estrogen. So as we said before, there's that surge, and then you build your bone up until you're in your mid-20s. And then as that estrogen declines in that 5 years around menopause, that's that big drop off that we're getting in our bone density. And then because your estrogen, it doesn't come back again, it stays low for the rest of your life. So your bones just continue to be chipped away at until you lead into osteoporosis. Men, it's quite different. Their hormones do drop off, but at a much more gradual rate. And obviously, they have more testosterone than women do at a younger age, and that's very good for building their bone density at that point as well.
Okay, so on that point, tell me a little bit about testosterone and bone and testosterone in women,
Yep.
and what the connection there is.
So, testosterone for men has been very well studied, and it has an anabolic effect on bone, so can help to build bone. In women, that phrase that women are not small men, it hasn't been as studied, but we would assume that it has a similar effect in women as well. And testosterone is also obviously thought to have an effect on muscle health, and just that whole musculoskeletal system the testosterone and the estrogen and your progesterone are all just working together to build bone. And I suppose if there is an imbalance in any of those hormones, it can affect your bone health.
And so does that mean, I know obviously both you and I prescribe testosterone um carefully, but do you use testosterone for someone who has osteoporosis, for example?
At the moment, that would not be on the Australian guidelines. So at the moment, testosterone for women, we prescribe it for women who have a low or absent libido. That would be the number one indication for when we prescribe testosterone. But it's not that unusual for me to see when we check women's testosterone levels that it's almost absent in a lot of women. And then it's having that conversation with a woman about what her choices are and what she wants to do. We have our guidelines, and then there's actually what a woman, if they've done their research as well, and what they want to do.
Yeah. I think for anyone listening, sometimes people do get a little bit surprised that women have testosterone and men have estrogen.
Yeah.
And I think for years we've had these hormones very much pigeonhole that, estrogen's all about pregnancy and periods and
Yeah.
in women
Yeah.
and about fertility. And I think we have thought of men as men have testosterone, and I think we have to really rethink
Mm.
how both everyone generally thinks of these hormones. They're
Yeah.
just human hormones, and we think about them more like messengers, that
Yes.
they are message suppliers all around your whole body. And until we stop kind of pigeonholing, because it is a little frustrating really to think, I mean, while I understand why the guideline is that testosterone is only meant to be prescribed in women with low libido. But, do we really think that testosterone only does that
Mm.
one job in the body? It
Yeah.
seems highly unlikely,
Yes.
given that there's testosterone receptors in so many cells in the body.
Yes.
So it's going to be really interesting to see. And I do suspect we'll maybe look back in 10 to 15 years'
Mhm.
time and be thinking, what were we thinking?
Well, we were talking earlier about that Louise Newson study, where she had, I think it was 900 women who were well established on estrogen and progesterone, and they added in testosterone treatment. And after 6 months, yes, libido for sex improved, but actually the top three symptoms that improved for memory were things like libido for life, that motivation and energy levels. Those were the main things that people actually noticed when they were taking testosterone. So I absolutely agree. I think it's not just about libido for sex.
Yeah.
If there was a receptor in every cell in the body, that's not all it does.
Yeah, absolutely. And I think some of the other things that she was able to show in it, because people kept saying we need more studies. Well, she, I think, has shown also that, musculoskeletal symptoms. So people did complain of less joint
Yep.
pain, less muscle pain, and also less bladder
Yep.
dysfunction. And you and I both know that that's a very common complaint as well.
Yeah, absolutely.
Anyway, I think we're going to have to watch this space.
Mhm.
So, if a man has osteoporosis, do we give him testosterone?
I don't know, actually. I assume that it would be something to consider to check their testosterone level. And I guess if their testosterone level was low and they had other symptoms of testosterone deficiency, that would be a factor in their treatment.
Yeah. Okay. Yeah, I think that's right. Okay. So, while we're talking about hormones, where does progesterone come into the mix with all of this?
So again, and I think, when we talk about progesterone now, we're not talking about the synthetic progesterones that are in things like the Implanon or the Mirena IUD or in contraceptive pills. We're talking about the natural micronized progesterone or prometrium in Australia. So it has a synergistic effect with estrogen. So whereas estrogen helps to tip that balance more to stop so much bone being reabsorbed. Progesterone can help to stimulate bone building. So they work together really to try and help the bones to stay more dense and to reduce that risk of fracture.
On Sunday morning, when I was out walking at Terrigal Beach, which is a local beach, I kept crossing paths with a number of women who all had vests on, just like me, weighted vests. And we all gave each other a bit of a knowing look because these have become very, very popular in peri and postmenopausal women. You might not know what rucking is, but basically what it is walking with either a weighted vest or a weighted rucksack. I personally opt for the weighted vest because I find it very, very comfortable and very, very quick to put on. So for peri and postmenopausal women, there are definitely a number of health benefits that you can gain from walking with extra weight. One of the health concerns that many women have at this stage of life is developing heart disease. And unfortunately, we know in the postmenopause, the rates of heart disease for women really start to accelerate. So why might rucking or walking with weight change that? Well, basically, whenever you're walking with additional weight, it increases your heart rate more, and it basically makes your heart exercise a little bit harder. So hopefully making your heart a lot more healthy. So that's one of the benefits of rucking in comparison to standard walking. So if you're intrigued and ready to start rucking, my recommendation would be that you start low and go slow. So start by choosing a weight that is 5 to 10% of your body weight at maximum, and take it slowly. Go for maybe a 10 to 20 minute walk at first. Don't decide to go on a 5-hour hike the first time you strap on your weighted vest. So we've been chatting to our friends at Rucksack, and I've got a special discount code for you. So if you go to their website, which is www.rucksack.com, so ruksak.com, and use the code Shauna15, so that's SHAUNA 15, you're going to get a 15% discount. So whether you decide to go for a vest or whether you decide to go for one of their backpacks, either way, you're going to get 15% off. Now, let's get back into the episode. What about strength training? Obviously, strength training, everyone's talking about, I think, two things: eating more protein and strength training. They seem to be like a nearly full-time job for women at this point. What is the connection between having strong muscles and doing strength training, and bone
And
health?
bone. So if we think about the way that our muscles work together with bone, um, if your muscles are largely attached to bone, and so if your muscle's pulling on that bone, it's going to stimulate some growth. And generally, the bigger the muscle is, then the bigger the pull. So if you can give yourself some muscles, then you're going to actually help your bones long term. But it's also just about then if you think that's probably going to help your balance too. And we now know that, the amount of muscle that we have is linked to how long we live. So if you think that, um, you're losing muscle as you age, which is called sarcopenia, there's that critical point that you get to, which if you tip over that and you've lost so much muscle, you can completely lose your independence. And if you think, well, if you're not independent, you're probably a high risk of falls, and then you're more likely to fracture your bones. So yeah, strength training is absolutely critical for a woman that has thinning of the bones already, but for all women really, then they should be thinking about doing some strength training.
And so then strength training and then balance as
Yeah.
well, because I have to say, I don't know about you, but all of a sudden I realized when I was climbing over some rocks at the beach, I was thinking, God, when I was a kid, I could just jump from rock to rock and not even think it. And now I'm
Yeah.
like some kind of cautious,
Mhm.
anxious wreck that
Yep.
I'm gonna like break an ankle. But it's like you don't notice
Yep.
that it's suddenly kind of crept up on you and you're
Yep.
thinking, oh my goodness, actually my balance is not as good as it
Yep.
was. That is all connected because, of course, if you have these osteoporotic bones and you fall over, well, it's not
Yep.
going to end well in
Yep.
comparison to if you've got nice, strong bones.
Yes, and you might have seen recently on Instagram, there's the little thread going around of trying to balance on one leg and kind of squat when you're on one leg, all those sorts of things to just try and test out your balance. There's all sorts of things, trying to stand on one leg when you're brushing your
Oh,
teeth.
my
All
poor
those
mother. I have her, my poor mom, who's in her 70s, and she's like, oh, telling all her friends, oh, my daughter says we have to stand on one leg when we're brushing our teeth.
Maybe you should tell her to do that while she's waiting for the kettle to boil because she
That's
probably has a fair few
that
cups of tea.
That's right. Well, also, she's very into craft, and I also make her say you have to sit on the floor and you have to just keep
Yeah.
getting up and down.
Yeah.
Because when you do look at the people who live in those blue zones and who are really fit, a lot of the time they actually do sit on the floor,
Yeah.
and they reckon it's that act of getting up and down and
Yeah.
having quite strong thigh muscles that
Yeah.
make a
That
difference.
protects them. Yeah.
I was chatting with a patient the other day, and we were kind of laughing, but it was serious. Her mum had fallen over at home and couldn't get up, and unfortunately didn't have her little necklace with her
Mm.
coal alarm, and her mum had lain on the floor for a few hours
Mm.
before anyone found her. And
Mm.
we were just talking about how frightening that must be whenever you can't get yourself up,
Yeah.
that you're actually
Terrifying.
at the
Yeah.
mercy of. And I think that really does make our generation go, okay, what can we do about
Mm.
this frailty thing?
Yeah.
Because, I think being able to get in and out of a chair means that you can get up and down and answer the door or
Yeah.
answer the phone and be sociable, or being able to get in and out of a car
Mm.
means that your family can come and take you out,
Yeah.
and being able to get yourself up and down off the toilet means
Yeah.
that you're continent,
Absolutely.
and
Yeah.
lose your thigh muscles and basically you lose your independence
Yeah.
completely.
Yeah. No, look, it's absolutely crucial. And I think that people like you and I have a real responsibility to women when we see them, that we impart this information. I think that looking ahead to frailty and being in a nursing home is not an inevitable thing. It's entirely preventable. And the changes that you make now, you have to do something that's sustainable for you, but you make a choice every day. But I think that's why, it's such a privilege what we do. We can, 100% change the trajectory of a woman's life by how we impart that information. I don't know how many times I've seen people that just get told they have osteoporosis. They might get told to just have this injection that helps to build your bones. We'll see you in 6 months. But I don't think they're given that full picture of actually, this is likely what's going to happen to you. Things will likely continue to decline. You may continue to have a fracture in your future if you don't do all these other things. And, you know, someone's only going to take that on board if we impart it in such a way that they understand that it's completely critical.
100%. And I think the other thing, which, I'm as guilty as any doctor of, is that perhaps we're not so good at explaining that, yes, you might have had a fracture when you were 10 and you fell off your
Mm.
bike, or when you played rugby or whatever. But the reality of an osteoporotic fracture is really quite different.
Mm.
You break, you have those fractures in your spine, and they're crush fractures,
Mm.
and you're talking about chronic pain.
Yeah.
It's not a fracture that's going to repair or
Yeah.
particularly get better.
Yeah.
And I mean, you and I both see a lot of elderly women who are in really chronic pain
Mm.
with, I think I see a lot of women with spinal
Yeah.
fractures and crush fractures and losing height, and being really stooped over, and really navigating chronic pain. And I
Mm.
think it doesn't have to be that way,
No.
but unfortunately it does. It's not an easy fix, and I think that's what we all, oh, me included, we all kind of want, don't we? Like,
Yeah.
the knowing and the doing are two different things.
Different things.
I
Yeah.
mean, we kind of know that we need to do these things, but sometimes it just feels really hard.
Yeah.
But then, of course, you and I get to see the people who maybe haven't been told or advised correctly, and you watch them and you're trying to get pain under control and putting them on morphine patches
Yeah.
to deal with bony pain, and you think, this didn't actually have to be
Mm.
this way at
Yeah.
all.
Yeah. And look, I think we have to be quite frank with patients as well at what the statistics are about. Yes, there's having these spinal compression fractures, but people can still live with that. But if you have a hip fracture, um, in that first year after that, you've got up to 24% risk of dying in that first year. 40% won't ever be able to walk again unassisted, and 20% will end up living in a nursing home. So to me, that's really very frightening. And I don't think women are really aware of that. I think there's lots of campaigns that go on around all the more female cancers and breast cancer and ovarian cancer, etc. But actually, more women have a hip fracture than those that have breast, endometrial, and ovarian cancer combined. So I think it's something that we do need to start talking about a lot more. And potentially, I would love to see that bone density scan brought down to sort of age 50, even that, it was brought up at every conversation at that sort of midlife check.
Yeah, 100%. I think, and rightly we, of course, always are cautious around female cancers and all cancers. But
Mm.
as I was chatting with our cardiologist colleague a few weeks ago, Dr. Tom Ford, I think in ways we've frightened women maybe about the wrong
Yeah.
things.
Yeah.
Everyone's, I remember watching a lecture once, and they asked, put up your hand if you're scared of.
Mm.
And it was doctors, and it was put up your hands up if you're scared of, and it was put up your hands if you're scared of breast cancer. And,
Mm.
everybody put their hands in the air, but put up your hands if you're scared of heart disease. And,
Yeah.
and not really many people
Yeah.
did. And yet, it's actually the number one killer.
Yeah.
And as you say, the statistics around a hip fracture are
Mm.
horrendous.
Yeah. Yeah. You've got a much higher chance of dying if you get it diagnosed with a hip fracture than you are if you get diagnosed with breast cancer. The
Yeah.
breast cancer survival rate is now,
Oh, it's
what, like
90, I think it's
90 plus? Yeah,
95%.
yeah,
For over 5 years. Or I mean, it's
yeah,
unbelievably
yeah,
fantastic and
yeah,
amazing. And that's not to belittle anybody. But, whenever you're talking about a statistic of 20%, that's 1 in 5
yeah,
people who will die in the year after their hip
yeah.
fracture. And 20% who, will go on to end up in a nursing home
Mm.
after that. And something like
Yeah,
that's 2 out of 5
yeah,
who are not coming
that's
home.
it, yeah.
And then another 40% of those people are going to be left, walking with a frame, walking with
Yeah,
assistance, no independence. Like, it's pretty horrific, actually.
it is, and as I said, it's preventable. That's the tricky thing about it. We can actually really do stuff early in life that will prevent that from occurring to us.
I've had a few patients recently who are very health conscious, and been doing deep dives into things, and they seem to be a little bit confused about the whole, do I take calcium? Do I not? Do I take vitamin D supplements? Do I not? And I know evidence is ever evolving, but where are you with that with your patients? Are you getting them to take additional supplements, or are you
Yeah.
trying to get them just to have it from food?
Yeah. Look, I absolutely try and encourage people to get it from food. And to be honest, if I get someone that has a diagnosis of osteopenia or osteoporosis, as part of that, trying to get them to change their lifestyle, I refer them to see a dietitian and to see an exercise physiologist. So the dietitian's there to make sure that they are meeting that calcium requirement. And say someone's, vegan, or they don't tolerate dairy products, there's fortified products, or then you can take a supplement. So it's 1,300 milligrams orally through your diet, or if you have to take a supplement, then it's a 600 milligram tablet. But I find most women can get it through their diet if they think about it.
So can you give me like a rough, like an idea of what you would eat in a day to get 1,300 milligrams? I'm sorry, I know I'm putting you on the spot and you're not a dietitian, but
Yeah, so say I'll tell you what I would probably eat in a day, because I don't take a calcium supplement. I try and get it through diet. So say I have oats in the morning. I don't drink cow's milk, but I have calcium fortified soy milk, and then I'll have a giant dollop of yogurt on top of that, and I'll maybe have some almonds on top of that too, which are a good source of calcium. Say for morning tea, I might have like cheese and crackers, something like that, or with some dried apricots, which are also a good source of calcium. And then sometimes I'll have like little tins of salmon at lunch. So eating those little tiny bones within that has got a really good source of calcium. And then having some sort of lean protein for dinner with veggies, and then you're probably going to be reaching your calcium requirement if you do things like that. So as long as you're not someone that completely shies away from having any sort of dairy products, then you probably will be getting up to that point of reaching your requirement.
oh, you're a better woman than me. Our dear friend Nicole, the dietitian, always talks about tins of fish with the little bits
Yeah,
of
yeah.
bone, and I'm like, oh, I cannot
Can't do
do.
it.
Oh, I just can't do both. So yeah, I'm not doing so well with that. Okay. So in terms of we've talked about why we need to be taking this a lot more seriously. Is osteoporosis an indication to go on hormone replacement therapy?
We can use it as treatment for strengthening the bones. And then if I'm seeing someone at perimenopause and they're already osteopenic, then absolutely the number one treatment is to be on some sort of hormone replacement therapy. So giving that estrogen through the skin and natural progesterone. Then yes, I would be advocating for them to take the hormones. As we said before, in that 5 years around the last period, in particular, you lose bone at the fastest rate in the few years before your last period. And clearly, if we're seeing someone for perimenopause, we have no idea where they are in that phase. So if someone's on hormones as they're going through that 5 years and we're topping up their natural estrogen, which is estradiol, they won't lose that bone. But the guidance would be that they would stay on the hormones for the rest of their life or as long as they wanted to, because we know that whenever you withdraw from that estrogen is when you will lose that bone density. So absolutely, it's indicated as a treatment, and potentially we should be thinking about it in more women as that first line treatment, even regardless of their age, and perhaps giving women the choice of what they would rather take. There's obviously a lot of drugs that are specific for osteoporosis, which are obviously all synthetic drugs, and then there's our now natural body identical hormones.
And without going into, minutiae of detail, what are the other treatments that you might be prescribed for your osteoporosis?
So probably the main class of drugs are called bisphosphonates. And yes, they will improve your bone density, but I think sometimes they can, yes, increase the density, but the bone might still be quite brittle. So they're still at risk of fracture if you fall. So those drugs can be either taken orally, usually as like a weekly tablet, but they can cause quite significant indigestion. So a lot of people really don't like them. And also there's remembering to take that thing once a week. And then you can also get infusions once a year of another drug that's also a bisphosphonate. Then there's a newer drug called Prolia or denosumab, which also builds bone, that's given as a 6 monthly injection. But once you start on that injection, we know that you can't actually ever really stop it without a plan, maybe to convert to something else. But when you stop it, there's a rebound increase of fractures. So someone has to be very much on the ball with doing that every 6 months. And then if someone is having fractures on those types of medications and, they've been on it for a while, they're still having a fracture, then there are some other treatments that are only given by an endocrinologist.
Right, okay. And what about osteopenia? Is there a treatment specifically for that?
It's estrogen, I would say, is the best treatment for that. At 19 when I had osteopenia, the main thing for me was actually trying to give me some sort of regular cycle. And look, I'm probably your worst sort of complicated case that you could get because I also get migraines. So I could never take an oral estrogen contraceptive pill. So maybe in those terms, I actually had the worst treatment ever. I was put on the progesterone only pill. Um, which, maybe was not the best thing in hindsight. I should probably just have been on nothing and tried to get my cycle back to being regular again. But yes, certainly women that are diagnosed with osteopenia, say they're over that age where they're able to build their bone again in their 20s, then we should be thinking, how can we give this woman back some estrogen to stimulate or to stop essentially that bone being reabsorbed so quickly?
And so we ask women, particularly whenever we're seeing osteopenia and osteoporosis, to do weight bearing exercise. Can you explain what does weight bearing exercise actually mean?
Yeah. So, yeah, not all exercise is the same. So, if you think about things like swimming, even being on a cross trainer or cycling, your weight is supported. So, that's not going to really do much for your bones at all. So, weight bearing exercise is really when your bones and your muscles are working together against gravity. So, doing things like you can run. Running on its own is actually not very good at building bone, though. If you think about it, you're just doing the same movement over and over again in one direction in one plane. If you compare that to something like a racket sport, so you're playing tennis or badminton or something like that, you're constantly just pivoting and changing direction, netball, anything like that, where you're sort of jumping around is brilliant for your bones. Even things like I don't know if you can do a box jump. I can't do a box jump to save myself. I don't know what it is about it. I can't get it in my head. I fall over every time. But even if you step up onto a box and jump back, you're still putting that weight through your bones. There's even some evidence, and Dr. Vonda Wright talks about just doing your 20 jumps every day.
I have my mother doing that as well.
Great. One that I probably do quite frequently is stomping around the house, angrily around my two little boys. So I'm sure I get my stomping steps in every day. And there's also this new thing, well, fairly recent thing about everyone's getting a weighted vest, which is actually very good for bone building. And if I've got a patient that's kind of losing weight or is trying to get fitter, and then we say, look, we'll put back on that 5 kilos that you've lost and wear it as a vest and just start walking, then you'll burn more calories, but also you're putting that stress back onto your bones again.
So I had a patient, and it gets brought up quite a bit. Is so you're encouraging me, doctor, to lose weight, and then now you're asking me to put weight back on.
Yep.
So can you explain why that's beneficial to do that? We're asking people to lose weight, but then we're asking them to put a jacket on with weight back on it. Why are they not better just staying overweight?
Yeah, so maybe didn't touch on that before, that a big risk factor for your bone health is also being slim. So people that have always been, had a lower BMI, they're more at risk of osteoporosis, just because they've put less weight and stress on their bones throughout their life. Whereas someone that is quite overweight, generally their bones should be in a bit of a better position. So, yes, when they're losing weight, then we want to just still stimulate that same stress that they were had on their bones before.
Okay, all right, that makes sense. So if you had a patient in front of you, so let's make up a patient that we would see frequently. Okay, so she's 45 and she's presented with some perimenopausal symptoms, and she's not sleeping. She's putting on some weight and feeling really exhausted and lethargic.
Mhm.
And she is having reasonably regular periods, but they're shorter and lighter than they
Yeah.
ever were. Alison, what were the investigations that you would send that
Yeah.
patient off to have
Yeah.
before you would do anything else?
Yeah, so everyone normally send them for some fasting blood tests. We want to look at those sort of metabolic markers, check their cholesterol level, their glucose, their insulin levels. And then I often check their vitamin D as well. It's quite common to find women that have vitamin D deficiency. And then say it is a kind of younger woman, I will check their hormones as well. I kind of know that they're hormones are likely going to be normal if they're still having a regular cycle. But often I want to know that testosterone level as well because it
And
can
it can
fall
be
quite early.
surprisingly low, can't it?
Absolutely. Yep. Um, so blood tests would be an initial investigation. I ask everybody to go and do a bone density scan. And I should also mention that some people ask about, they might say, oh, I had a body composition scan and my bones were fine. But a body composition scan can be falsely reassuring because it tells you about your total bone density throughout your whole body. So it doesn't break it down into those individual sites. So we really want that gold standard test of a bone density. So I'll get them to do it again, annoyingly. And then I want to make sure that someone's up to date with all their screening. So making sure they've had a cervical test, that they've had a mammogram within the last couple of years, and just all their screening, bowel cancer screening. I get asked people if they've had their skin cancer screening, but those are my sort of normal investigations. And then depending what those come back like, then we have another conversation. The only one that I now get a bit concerned about is say someone has had a family history of heart disease at a very young age. That might be the only time that I consider doing some extra cardiac investigations after that initial consultation.
Yeah. Can I ask you about another theoretical patient who
Yes.
you and I know see a lot of? And so this patient is 60
Mhm.
and they unfortunately fell into the era of the WHI. And I think, admittedly, you and I probably were guilty both of not prescribing people HRT 10 years ago. And so a group of women who have never been even offered HRT and who are hearing all about everyone talking about hormones, and they're coming in and wanting to know, is it too late for me? And she thinks she had her menopause somewhere around 50, 51. So we're 9 or 10 years
Yeah.
out. What would you do in that situation? And again, obviously this is very
Theoretical.
individual
Yep.
and individual, but I just I know there'll be people listening and thinking, is it too late for me,
Yep.
or is it too early for me to go?
Yep. And look, obviously we'd go through that whole screening pathway again. But yeah, it's absolutely not too late for somebody. The studies show that estrogen can have the same impact as a lot of the specific osteoporosis drugs that we mentioned before. So I think it's part of our educating a patient that it's on the table and then letting the patient make their own decision as long as there isn't any reason that they cannot take hormone treatment. The study that put us all off HRT in the first place more than 20 years ago actually has really great evidence for what estrogen can do for your bones. And I think that the women that had estrogen during that study, they had a 40% reduction in the risk of osteoporotic fracture. But yet that study put us really off any form of hormones. So absolutely it's on the table, but as you said, it's that detailed individual discussion.
Yeah, amazing. And I just want to just segue back quickly. You talked a little bit about, we often see this vitamin D deficiency in women. Why are we interested in vitamin D, and what is, obviously there's a bony connection, but is there other symptoms that you can have from vitamin D deficiency?
Well, I often check it because women are absolutely knackered or using usually during this phase. They might not be sleeping well, but they also just feel like really tired and run down, and that can be one of the symptoms of a vitamin D deficiency. So I usually screen for it anyway. But you know, getting your vitamin D from the sun here in Australia, it sounds like it's going to be easy, right? We have nice sunny days, but the sun is so strong that a lot of people are trying to be sensible and stay out of the sun, or they're slapping on their factor 50 and their wide brimmed hats. And then it's quite common for us actually to become vitamin D deficient. We can't absorb vitamin D through sunscreen. And I actually think we probably should all be vitamin D deficient if we were being sensible. But it doesn't take long to get your vitamin D, but it's got to be at that certain time of day, very early morning sun, late afternoon, even what I'm wearing now, your sleeves rolled up, not no sunscreen or anything on your face, and it takes about 20 minutes. And if you can try and do that kind of every day, you're probably getting enough vitamin D. But for me, I take a supplement. I don't want to risk that I'm not having enough vitamin D because that's what's helping to absorb the calcium from my gut to get put into my bones.
Yeah, amazing. Thank you for confirming that. Alison, I have to say, to anyone listening, Alison and I work together, and it's just such a privilege. I think we both have a very similar the way we both approach peri and postmenopausal patients. I love that you've got such a holistic approach, and we both have made that decision to really take our time in our consultations and have very long, in-depth conversations. There's often tears in the consultation room, and there's lots of frustration often because patients have maybe been round the block and seen lots of people and heard lots of no's. And I think that, women are often out there quite exhausted and sort of fatigued, not only with all their perimenopause or menopausal symptoms, but also that stress of thinking, oh, am I going to come into another doctor and be told, oh, well, your bloods are normal.
Yeah.
So it can't be.
Go.
It can't be the perimenopause. So I just wanted to say thank you for all the women that you're helping. Is there anything else that you would like to talk to the listeners about that we haven't talked about already to get our message home?
Yeah, look, I think I would just encourage everybody to just think about your bone health. If you haven't had a bone density scan, just go and get one done. I'm sure you're the same, where I see women all the time and maybe they are carrying a bit of extra weight and they just say, "Oh, my bones will be fine." And I think, well, maybe they are fine. And then I'm shocked when I get it back that actually there is thinning of the bones. And then vice versa. I see other women that are very skinny, they're not really exercising, they're quite sedentary. And I'm thinking, oh, I'm a bit worried about your bones. And they come back completely normal. So I think we can't really predict just by looking at somebody what's your bone health going to be, but start to just think, do I have any risk factors? What does my life look like right now? Am I optimizing all those things a bit for my bones? And if not, just go and get one done. It could be the best like $100 you've ever spent.
Yeah, I agree. Alison, what is the piece of advice that you would like to give your 20-something self if you could talk to her? It's very poignant given how we started this conversation.
It is. And look, I was thinking about this because obviously I know you're going to ask this question. And Sonia stole my one last week and said she wished she could tell herself to not people please, because that's me too. But when I thought about it more, I was like, actually, I wish I could tell myself to stop worrying about the number on the scales. I think like a lot of women, the number on the scale and what I look like or how skinny I am has shaped kind of how I've been in my life. And I wish I could tell myself that mantra of strong over skinny and focus on what my body can do, and that I'm not that chubby little kid that's not good at sport. I can do really hard things and just give myself that encouragement.
Yeah, amazing. I have to say, one, I didn't know that, and two, my perception of you is this super fit woman who runs like a crazy thing and who has always looked just the picture of fitness and vitality, really.
Yeah.
So,
Well, thank you. But I think like a lot of women, to gain, if you see a woman that has muscle definition, they have put a lot of time and energy and effort to get that muscle. I think a lot of women worry, if I start doing weight training, I'm going to bulk up.
oh my God, I completely forgot to talk about that. So many women go, oh, but I just don't want to get bulky. And I'm like, do you know how hard it is to get bulky?
So hard. And I'm sure I'm like a lot of women where I know that to gain muscle, I have to eat a lot more. Obviously, we didn't touch on protein too much, but you have to eat so much to gain muscle. And obviously, then you gain weight. And there's still a thing in my head that if the scales go up, that's wrong. But that's, I think, what a lot of women need to change in their mindset, that building that muscle is so important. And yes, the scales will go up, but that is okay.
Yeah, amazing. Thank you so much.
Thank you for having me.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.